Oh, perfect. Thank you, Tiffany. Without further ado, welcome again, everybody. This is AOC PMR, American Osteopathic Colleges of Physical Medicine and Rehabilitation, our monthly journal club hosted by our research committee. And this month, we are so excited and so honored to have our very special guest, Dr. James Atchison. Dr. Jim Atchison is a graduate of Ohio University Heritage College of Medicine. He did his residency at Ohio State University, some would say the Ohio State University. And ever since then, he served at academic institutions focusing on non-operative spinal care and rehabilitation, spinal manipulation, and comprehensive pain. We were actually talking yesterday, and low back pain is something that Dr. Atchison has been following throughout his career. So this is going to be a fantastic lecture this evening. He has been a leader in the field of PM&R, serving at the Rehab Institute of Chicago, now known as Shirley Ryan Ability Lab, as the director for the Center of Pain Management. And now he serves at Mayo Clinic in Jacksonville, Florida, as the chair of the PM&R department there, and has a joint appointment with the physiatry as well as neurosurgery, as he is the co-director of their spinal center at Mayo Clinic in Jackson, Florida. Dr. Atchison is very well known in the field, and we are very lucky to have him. He is known as an educator and a mentor. Without further ado, Dr. Atchison, thank you for your time today.
Thanks, Nick. It is a pleasure to be here and to kind of go back through. I enjoyed putting this together. I hope everybody, when you come to a journal club, you usually think about reviewing the article itself. And I'm going to add a little history pre-article and history post-article, trying to give you all a flavor of exercise with low back pain management and how it's changed over the years and does continue to change, because even after we've looked at all these studies, you're going to find out that there really is no single answer yet. So you will be battling this. If you go into PM&R, you'll be battling the changes and trying to figure out what's best for each patient as you keep moving forward. I'm going to see if I can get my screen up here and share things. I am going to use some slides, since we're talking about the history too. Let's go home first. There we go.
Perfect.
All right, we should be ready to roll. So no relevant financial relationships or off-label use. Nobody pays to study exercise, which is one of the challenges with people doing research in exercise for low back pain. It doesn't generate a lot of money, so they have trouble getting grants and the ability to fund their projects. I've practiced now PM&R spine medicine for more than 30 years as an osteopathic physician. I want to focus on the exercise programs and how we use them in our treatment. And I still do use manipulation as part of that. So the days where you're in OMT lab and those areas, you need to pay attention if you're going to go into PM&R. It's a tool that you will have as a DO that some of the MDs don't. And it does make it or give you one more tool in the toolbox so that when you're doing things, you have options to look at. So if we look at the paper itself, as with any good paper, you're going to go through different sections. And in the introduction, we're going to try and find out why they did the study, how did they do the study with the methods and design, what did they find out as their results, and then how do they think those are important comes into their discussion and conclusion. And also in the discussion, they would often talk about what perhaps they weren't able to do or the limitations of their study. And so tonight we want to talk about how we do analyze a paper correctly, but beyond that, we're going to do a little bit more than just look at this one particular paper, because I chose a paper from the DeLitto group, which is at the University of Pittsburgh. And part of it is there's about a 20 paper staged history of things that began before this paper and have continued after this paper as they've tried to piece together answering questions regarding the use of exercise in low back pain. So prior to this paper coming out, there were several proposals about classification subgroups. The LITOs started in 1995. There have been other proposed classification groups that have been studied. We're not going to go through all those different ones. I would tell you, when you look at this, since we're talking before the paper, 2008, after the paper, that's when the studies really began to heat up more for looking at McKenzie's classification system for management of low back pain with exercise. And we'll talk about that a little bit more at the end. But a lot of what triggered this were the AHCPR guidelines back in 1993. Agency for Healthcare Policy and Research is what AHCPR stood for. And this was really a government-sponsored project with hundreds of reviewers, probably 40 on the committee, trying to put guidelines together as to what to do to manage low back pain, because it was becoming an epidemic in our society and really was becoming financially very difficult to manage from insurance standpoint, and what worked and what didn't. You hear the term red flags when you're talking about low back pain. This is looking for tumors, looking for fractures, looking for infections like a discitis, making sure a patient doesn't have neurologic compromise or what's called Cauda-Equina syndrome. The red flags started with this AHCPR guidelines. From a treatment standpoint, though, the AHCPR guidelines were very minimalistic. They came out with what you probably shouldn't do. Up until this point in 1993, people often said, go to bed, get out of bed in a couple of weeks and see if you feel better. Well, that's not really an active approach that we would think about in PM&R. So I took it as a good thing. The paper said limit bed rest, limit modalities such as ultrasound, hot packs. Those have been very popular, but don't really show a lot of benefit. It did support the use of manipulation in a certain time frame interval, which was appropriate, and there had already been a lot of papers looking at that. So this was probably one of the most accurate areas for actually having literature to support what the guidelines would say. Part of what came out of this, though, is do we need PT to really treat people or not? The paper was really, or the guidelines were really supporting minimalistic care. Educate patients, 90% of you are going to get better, that you don't want to go to bed, you want to stay up and maintain your activity levels. But it was thought that perhaps just telling patients this would be enough to let them get better. And for some patients, that is probably true. However, there are many people who hurt their back and it's not true. So we still have a lot of different things to look at in treatment. One of the things I've always taught to students, residents, and fellows that I've had is the guidelines in general are true. You don't need an x-ray right away. You don't want to do bed rest. You don't have to follow a particular PT program. But the idea is, if you show up in my clinic in day 1 or day 2, you're looking for treatment. You want to know what you can do to help make yourself better. The people who don't probably need any treatment at all don't show up in my clinic. They are staying at home. They're like, well, it'll get better in a week or so. I'll just kind of work through it. So from a epidemiologic standpoint, most guidelines started to look at limiting formal therapy. But one of the challenges was these aren't the people who show up in your office. It's the people who don't really need treatment that don't show up in your office. They're able to get better on their own. And that's part of the 90% of people who get better no matter what. We talked about the classification groups. We're going to go over those within the paper that we're looking at here. But we do see that the 1995 was kind of the start of this sequence. What we're going to do at the end is I will send a PDF to Nick with the slides on them. So I didn't prepare a separate reference sheet, but you can go in and you can pull out the references right off these pictures from PubMed that we're going to use throughout this. All right, so before we get to the paper we're reviewing, after the 1995 proposed subgroup by DeLitto, they went in and they started doing things with trials and doing research and trying to show what was true and what wasn't true. One of their first work was comparing the clinical practice guidelines, which said, do low-level aerobic exercise, maintain your activity level, education, but you don't really need any formal therapy, to using these classification tools. And they found that people did better with the PT than they did with the not PT. This, once again, was a group that had been referred to a clinician, and so they were looking for treatment. And this is part of what we see throughout all of low back pain management is when people believe they're getting the correct treatment or they think this is the right treatment for them, they do much better than when you're really prescribing treatment that doesn't seem to fit with them from a mental aspect. The group, DeLitto and his group, went on to validate their different groups, looking at would their assessment work in the spinal manipulation group. As you go through osteopathic training, you're going to see more and more of what we now call clinical prediction rules, trying to look at what pieces of history and physical exam actually determine who is potentially going to benefit more from spinal manipulation and who is not. It's not always right, doesn't work perfect, but if they have 4 out of 5 of the identifying abnormalities, they're more likely to get a response from manipulation than if they don't have those. So this is important for me when I'm a clinician using manipulation to be able to think along the lines of what do I want to do in my assessment to determine that. They've looked at clinical prediction rules for some other areas in their different exercises. And that's kind of where we're heading into this process right now. Go back up for a moment here. So these are the references once again for those 3 papers I just went through. So you can go back and pull those out if you want to. Specifically from this paper, when I look at the introduction, what do I see? Well, I see a sentence in there that says the utility of a pathoanatomic classification method for non-surgical management. You guys can read this. It's a big sentence. What does that mean? Well, basically where we got to in this stage of our evaluation of patients is everybody's getting an X-ray, then they went on to having CTs, then they went on to having MRIs. And most of these studies don't show us why they're having pain. So there is very limited findings that are clearly diagnostic for the pain pattern that people have. Most studies, as we age, start to have more and more generalized findings. And there's a whole lot of research, or at least report out there, about normal or studies done in people who are asymptomatic, have no low back pain, no history of low back pain, but they have radiologic abnormalities. And obviously these become more prominent as they age, but they don't help us sort things out. So one of the reasons that they started looking at the things they did is because there aren't good ways to look at a patient and try to classify them into the right setting. The other sentence that stood out to me from the introduction is the idea in their hypothesis that classifying patients with low back pain based on their signs and symptoms and then treating them correctly within that subgroup will produce a better outcome. This is what they showed in that 2003 paper. That to me is a fascinating paper because they took 70-some patients with acute low back pain that were injured workers. And if there's ever a tough population to have get better and to study, it's injured workers, but they managed to show in this population that the classification treatments, giving people what they would in the right setting from a clinical standpoint with a very experienced PT, did better than non-specific treatment, which is what most guidelines were proposing at that point in time. So as they moved into the current paper that we're reviewing, some of the questions were, does any exercise work? Does it really have to match? And that's one of the things they want to answer in the paper we're looking at tonight. Does it do better to have the matched exercise versus any exercise? Because that's part of what we might say is true. If a person does nothing, or if they do some exercise, they probably get better than if they don't do anything at all. But also still unknown, and through this time frame, is what is the correct dosage of exercise? In PM&R, we like to think about frequency, duration, intensity, probably different based on what you see on your exam for each of those areas, but we still don't have a good handle on that. And this paper was going to try to solve some of that. We'll talk about how it probably didn't answer any of that question. Keep in mind, from an osteopathic standpoint, once again, within the clinical groups we're looking at and classification-wise, manual treatment or manipulation is one of the groups, and identifying the right people for that group, we'll see, was effective in showing that manipulation has benefit. My editorial comment, once again, as a practicing DO physiatrist, is that you really want to combine manipulation with exercise together. As we move past the introduction on our paper, we get to methods in the study design. And obviously we have to look at inclusion and exclusion criteria. And part of the reason we do that is to have you think for the future, okay? I read this paper and I'm going to treat a patient sitting in front of me. Does this patient fit what that paper said? So you would think, okay, is my patient sitting in front of me with low back pain? Are they between these ages? Have they had it for less than 90 days? And what is their disability rating score? Now, the Oswestry is a self-report measure. It's not used in every office. It's not used in probably most offices of PM&R because there's so many forms to fill out these days and things to do. So you won't really know if your patient has an Oswestry greater than 25. You may rely some more on what you'll see on your physical exam when we talk about that. If you do the Oswestry, it's going to add a piece of information that you can follow. And their outcome measure in this study is the Oswestry, which is a disability self-report measure. It is not a pain and necessarily functional measure. So keeping in mind what we're going to be studying here is the disability report of the patient. In this group that they looked at, they took out a lot of patients to make it a more homogeneous population, including those that are pregnant, those that have had symptoms greater than 90 degrees, if they have nerve root compression, meaning radiculopathy moving into the leg. And that's one of the reasons in DeLitto's work, there's a fourth group, which is traction, but they use traction mostly with nerve root compression signs. And so in this paper, they did not have a traction group simply because they excluded those people on the initial evaluation and criteria. The last statement there under exclusion criteria, the inability to reproduce symptoms on our exam, is interesting. They hadn't explored this a lot yet, but as papers grow towards 2021, where we are now, this is a group that probably has more psychosocial overlay and some components to their pain that are different than mechanical and structural, and they need treatment possibly with cognitive behavioral therapy or other relaxation techniques or things different than that. But in this patient population, for the study they were doing here, they excluded that group. The treatment groups were predetermined. There's manipulation, specific exercise, and stabilization. We'll go through what each of those is. They were supposed to get treated 2 times a week for 4 weeks. with the oswestry at baseline, with the oswestry measured at 4 weeks, and then the oswestry measured again at 1 year. All right, so just quickly what was in the manipulation group. And I'm going to show you some pictures of different thrusting maneuvers and exercise like they could do. But one of the things you're going to see in this treatment is there's a lot of variability. And when we get down to numbers in our results, the numbers are pretty low. And yet the therapist here in the manipulation group, if the person was randomized to manipulation, they could get thrusting, or they could get low amplitude mobilization. They could get it to the sacral area, or they could get it to the lumbar area. They then got an exercise in either the flexion or extension position in the quadruped, which is simply a motion activity. But there is some variability within the group of who got what. Just picture-wise, since it wasn't in the paper, this is the pelvic sacral mobilization and manipulation that was used when you look back at some of the previous papers. This is from when I was back at the University of Kentucky. This is Dr. Scott Stahl, who was one of my residents then, went on to be the chair of manual medicine at the Texas School of Osteopathic Medicine. He's stabilizing that right sacral and pelvis area while he does side bending and rotation maneuvers down to the level that he wants to mobilize. This is classic lumbar manipulation, the lumbar roll, as it's often called. Person's on their side, he's bringing their knees up towards their chest. He then rotates the one knee forward. He's pulling, in the second slide on the right, he's pulling her left arm towards him to rotate back in the opposite direction. And then once in position, the thrusting or mobilization maneuver comes with his left arm through the sacrum and pelvis pulling towards him while he stabilizes with the right arm. So these are pretty classic manual treatments, but there was variability. They also then were doing exercise with flexion and extension in the quadruped position. For those of you who aren't aware, quadruped means on your hands and knees. So simply moving the back up and down. On the left side, we would see a flexion component because the trunk's actually flexed. In the right side, we would see an extension component as we let the abdomen drop so that the lumbar is in an extension maneuver. For the specific exercise treatment group, this is designed to be a directional preference. So they could do either flexion or extension maneuvers, depending on which was more symptom limiting on the assessment. So we have a specific treatment group, but some got flexion, some got extension. And we don't, and from the paper, they didn't really tell us how many of each of those got what. These are some of the classic flexion exercises back in the early 90s. These were part of our regular routine: double knee to chest, single knee to chest, single knee to chest with extension, meaning while I was holding my knees, I would move that left leg down actively to do that. This was part of what used to be known as the Williams flexion exercises. Prone or extension exercises on the stomach, arching the back, taking the back then as it's arched and doing alternate arm and leg extension with that. These are exercises, once again, if they were doing them correctly with directional preference, would make the back feel better. And you show them to people at first and they're like, oh, I don't think that looks like something that's going to make me feel better. So taking the right assessment tool to determine the right exercise. Prone press-ups are another method of doing extension where you have a little more support through your arms and you're trying to mobilize the lower area once again. The stabilization group, which was their third different group of treatment, looks at exercises that are trying to really strengthen the core abdominal area, as well as the posterior core, which includes the gluteals and certainly the side muscles for the gluteals, or even the rotators through the lower distribution, like the multifidus and some of those muscle groups. Abdominal bracing is simply contracting the abdominal muscles to move. You can see forward and backward where my hips were moving up and down. but in that bracing position, then starting to use arms and legs. This is in an unloaded position, right? This is not functional for daily activities, but eventually in therapy, you would take this from being unloaded and doing more in a standing upright position and in other areas. You can advance quadruped exercises with the alternate arm and leg extension once again to make you work the glutes and the abdominal core. That exercise on the right, I don't know that I could do today. These pictures are from a while back when I was a little more fit and active back in that time. Curl ups in order to try and strengthen the isometrics of the abdominal was part of that core stabilization group also. So those are our specific exercise groups that were in the paper that they are going to use, but there is variability within them. And then once that exercise or treatment, including the manipulation, started to work, then we were trying to progress the patient to what they called stage 2. So stage 2 occurred if the treatment up to that point had improved the oswestry to less than 20 or had reduced it from 33% of baseline. But to get there, not only were they doing their specific program within their group, the paper did mention, and if you read carefully, that modalities could be used at the discretion of the therapist. So they could have used heat, they could have used cold, they could have used ultrasound, which is a deep heat, different than the ultrasound that we now use for most diagnostic purposes. There was a whole bunch of modalities back in that day that generate a lot of money, and they could be used, but no report in any of the results about who did or did not get those. There was no set number of exercises per session. And then there was no discussion about whether they were told to do the exercises on the non-treatment days. If you remember, they were being treated 2 times a week for 4 weeks, formally with the PT. And there certainly is no literature that says this is the golden window of what you do. So should they have been doing it on the alternate days or not? These are still many, many questions from that time frame, and honestly, that continue through today. When they were trying to get to stage 2 of the protocol, that meant if they were improving with their specific treatment, they were all then moved to low stress aerobic exercises, addressing any specific muscle group limitations for range of motion or strengthening, and doing more stabilization exercises. Now, the one group got stabilization right from the beginning. The other groups had it added. The reason it was felt to be important is there is a pretty good paper from many years ago that showed 70% recurrence rate with low back pain unless you maintain your exercise level and strengthen. So the idea of trying to prevent recurrences is really one of the important things in doing an exercise program and perhaps in doing the matched exercise program. However, that was not one of the assessment tools that was used in this paper to evaluate success or not. And then the patient was allowed to continue any of the stage 1 exercises that they wanted to do. All right, if we continue through the methods and study design, as we said, baseline had oswestry. They did measure VAS, which is your visual analog score of 0 to 10. They didn't use it in any of their data report. They also did what was called the fear avoidance belief questionnaire, which is becoming more and more used as we get into later papers and now into 2021. This is one of the study, or this is one of the groups of papers that would say people are having a fear of motion, a fear of movement, a fear of recurrent back pain and injury, and we have to treat them differently. But they took this measurement, they didn't really do anything with it. What they were reporting on the end is the oswestry changes, the progression to stage 2 of treatment within each group, and the number of visits it took to get to stage 2 to see if there was a difference in matched versus unmatched patients. Pardon me, I'm out of practice from talking here. So the randomization part was good. They did this ahead of time, so they just pulled a number when the patients were put into the study. The therapist received the assignment. They had to perform that particular exercise or treatment program, whether it was manual or specific exercise or stabilization. It was blinded. However, the therapist to decide, did you do flexion or extension in your specific exercise, was going to have to do some assessment. And to decide, should I manipulate your sacrum and pelvis or your lumbar area, is going to have to do some assessment. So in general, most parts were blinded, but there had to be some therapists, if you will, unblinding to be able to put people into the right treatment within that subgroup. The classification subgroups were what DeLitto had reported all the way back in '95, and they are based on physical exam assessment as well as some of the history maneuvers. They had 2 experts from their PT group review all of the baseline, which was done by a separate therapist, the non-treating therapist. This was very well blinded. And then they looked for whether that was matched or unmatched in terms of, did the group getting treatment get the right treatment based on what classification group they would have been in. So the design, I think, was very good. It's thought out well, and trying to do these assessments afterwards rather than up front makes it even more, adds more strength to the paper. What they were trying to do in their hypotheses was look for, does treatment to the matched group do better than treatment in the unmatched group? Meaning, I'm actually in the manipulation subgroup, but I got the specific exercise treatment. And this is where they were looking at the numbers to see how did that impact based on the Oswestry, which I mentioned to you before is a self-report disability assessment tool. And they were also looking at the groups to see, was there a difference in how many of them, if they were matched, actually got to stage 2 of treatment within the 4 weeks, or did it take fewer sessions for them to get to stage 2? Any good paper should also have a power analysis, because when we go through the results, we're going to talk about our groups and do we have enough subjects in each group in order to be able to tell a difference. And they had in the section on power analysis, and they determined that it would take 120 patients randomized to detect a minimal clinical change, which they define as a 6-point change on the Oswestry. The Oswestry is based on 100 points. A 6-point change, in my opinion, is not really a clinically significant change. And we're going to see some of that as we go through, whereas you're reading papers and you're analyzing the results to decide, are you going to use this information in your practice? There is a difference between statistical significance and clinical significance. But theoretically, they went in thinking, if we had 120 patients, we're powered correctly. So they did properly set this up to do it. Now, let's run the results here as we get going. We see over the time that the study went on that they had 1,052 patients referred with low back pain. Most were ineligible because they were outside of the age window or they were outside of the chronicity window. They had 268 eligible people, which they talked to. They were able to consent 123. So they made their 120 going in, right? They then randomized these patients into treatment. And based on pulling the numbers for the randomization, they ended up with pretty good grouping. 40 patients manipulation, 46 for stabilization, 37 for specific. Those are pretty good within a study. When we go back and look post-treatment at what group should they have been in, we find that a larger percentage of them actually would have been in the manipulation group, and Remember, manipulation included not only the manual treatment, but the exercise that goes along with that. And then there was smaller populations in the specific exercise and stabilization groups. Still, they're doing a good job of reporting their results to us, but you're starting to see we're getting down. We've got 40, 46, and 37 in our different treatment groups. And then we're going to find out some of those didn't follow up, right? So after looking at treatment and classification groups, we find that there was a total of 50 matched. And you can see which particular groups those were in. 73 were unmatched. So 59% were unmatched. So when we're looking at our comparisons between matched and unmatched, the unmatched group is going to be significantly larger than the matched group. We see that for the two groups, they received pretty similar therapy though. I mean, 6.5 to 7 sessions is no difference. At least 77 to 80% attended 4 sessions. So not a lot of variability there, although we did talk earlier that there's variability within the groups. So as we look at further comparisons, we see there were more females in the unmatched group, which is interesting because there was actually fewer females in the study than males. Pardon me. We see that 10 patients did not return after baseline. So we started with 123. When we did our 4-week, when they did their 4-week analysis, we're down to 113. Okay. So what they used was their baseline score and assumed they didn't get any better. So that statistically, when we see matched versus unmatched is better or not, there's no variability from the baseline in that group. So if anything, this is going to show less improvement. And so this is the safe way to go in terms of doing the statistics. The long-term follow-up, which was at a year, got down to 81 patients completing that. And they took all of the ones that didn't follow up and left their original 4-week scores. So once again, we're getting to the point where we don't possibly know what's really true at 1 year because the numbers are continuing to dwindle. These are not unusual numbers. So when you're reading a paper, once again, I would tell you, losing 10 out of 123 to start with in human subjects research, that's not bad. Your 66% follow-up rate at 1 year is a little low, but yet since there was only 4-week and 1 year and nothing in between, it's hard to keep those people engaged. So that it's not horrible, but still you'd like to have better numbers to be able to really interpret the information. So just over time, did people get better? Looking at the treatment groups, the classification groups, if we just compare it to time, there is no relationship to just getting better over time. The relationship is really as they propose. Patients receiving the matched treatment had a better improvement in their oswestry at 4 weeks. Statistically, you see the p-value there, which is good. And at 1 year, even better. But we are still going to have to debate whether 6.6 points on the oswestry is a clinically significant improvement. The stage 2 analysis about which groups got there showed no general difference just in the groups, but it did show once again that the matched treatment group was more likely to progress to stage 2. No difference in the number of visits to do that, but more of them got to stage 2, which is felt to be a sign that their disability and their low back pain is dwindling, which is what we want in the treatment. So what did we learn if we go to the discussion from this? Some of their points were that one type of treatment is not effective for all non-specific low back pain. Okay, I think generally you can show that in a lot of different ways, and they probably showed that even before they got to this paper. Clinical outcomes can be improved when the initial treatment is matched to the correct subgroup. Statistically, that is true. I would tell you, if I was looking at that patient in my office, or if the therapist was looking at that patient in therapy, I don't know if they'd be able to see a difference in that clinically. So still some question along those lines. They were consistent with the clinical prediction rules that they'd already developed for manipulation and stabilization. The manipulation group did well. Once again, combining that treatment with some initial exercise and then advancing to other stabilization exercises in stage 2 was important. That is how I use manipulation clinically. I've always used it in short bursts up front while I get them started on their exercise program. As they get more independent with their exercises, they don't need me to do as much of the manual work, or a therapist to do as much of the manual work. So I think this fits right in with good osteopathic PM&R management. And then once progress is started, do we know what needs to happen next? And I'm not sure we learned that from this paper, but that really wasn't the focus of the paper. So hopefully as this group continues down the road, they're going to give us more information on that. We don't know what to do yet with a person who has milder low back pain. To get into the study, you had to have a Westry greater than 25%. So a person that comes in with low back pain and rates it lower, we may or may not find that they would fit in with this group. We also don't know exactly what went on within each treatment group. So how many exercises, when people come to therapy, they want to know, do I do 10 repetitions? Do I do 5 repetitions? Do I do it 2 sets? Do I do 3 sets? Do I do, the kind of the things along those lines that exercisers want to know in their prescription? We still did not really get a clear picture of that. We also didn't learn who does not need formal therapy. We still think there's a group, and they'll go on to show this in later studies, that doesn't need to come to therapy, that they can get by with education, mild aerobic exercise, starting on any particular group of exercises will help them along the way. But predicting that group up front before putting them through the therapy would be a really, really good idea. We also don't know what to do with the chronic. This looked at acute low back pain. And it was fascinating because the HCPR has been dissected for now almost 30 years, and it's for acute low back pain. Well, statistically, I saw the other day, 94% of the population now gets low back pain, and 90% get better. It's a little slower than it used to be, but really the issue is chronic low back pain, and none of the guidelines really seem to tackle it very well. And that's still where our biggest challenges are. We don't know anything about the traction subgroup from this study because we eliminated those people on the front end with our exclusion criteria, and the people with high psychological distress and low back pain need to likely be treated different. And that's part of the conclusion they'll come to down the road. So let me finish for their conclusions. And if you read the paper, you've already seen that. Hopefully, we've made the case that statistically this is true. Clinically, when you're sitting there thinking 90 to 95% of the population gets low back pain, am I going to base my treatment philosophy on subgroups of 14, and 22 or 24, I think it was? Those are pretty small numbers to make very, very large extrapolations into what we do. So those are the things you want to keep in mind. It's an excellent paper, and they did a great job with the design and the things to do with it. And recruiting human subjects is very, very hard. However, the numbers for this particular problem are pretty low. For some other problems, they might be great numbers. But for low back pain with its prevalence, these are pretty small numbers. So then the question becomes, what have we learned since then? I'll run through these real quick so we can get to questions. But after this paper in 2006, DeLitto and this group restated their classification symptoms, and they continued to work on trying to develop validity and interrelator reliability so that any clinician could do what they do. And that's what we want to get to is, in your office, can you do and reproduce what they did to make those decisions? Because for early maneuvers, it took a very skilled therapist or a very experienced physiatrist or family practice doc or any of who was seeing patients with back pain, but you had to be pretty skilled in what you were doing to try and to discern segmental hypomobility or some of the other things that were in there. So they're trying to make it simpler and easier for prediction rules so more clinicians can do it. This requires interrelator reliability studies. This requires validation studies for other things to do that. And they did a lot of this work. So it's been kudos to them over time for this particular pathway. The McKinsey people have done tons of papers with this also. That classification system first got proposed in 2008. And then if we move all the way up to 2018, trying to put together a lot of their papers to do a meta-analysis about this. But the meta-analysis didn't show that pain was dramatically changed with being in the correct treatment group from McKinsey. There was some decrease in disability report once again, just like the Olestri would be. DeLitto went on with his group and many other therapy groups from around the country to work on guidelines for the American Physical Therapy Association regarding low back pain. This is a very comprehensive review, 65 pages or so long, but they tried to break down and include subgroups, not only their own, but all the other groups in order to try and make this functional. I think if a therapist coming out of training only does low back pain for a while, they can get to be very good at doing some of these things. Once again, not every therapist and certainly many physician clinicians aren't going to be able to follow some of the pathways with this. Some things though that do keep coming up through all of the reports are we have to use the red flags, which go all the way back to the HCPR guidelines. A person with serious medical problems can have low back pain. Well, you don't treat that the same. You have to go after whatever the medical problem is. Same with significant psychological problems. And you have to treat that. You can't just treat them for their low back pain. So how do we make sure we don't have some other issues going on? That's really the role of the clinician a lot of times for us to do that. And then are we going to see improvement if we go through different match treatments to what would be proposed? Not everybody can do that. And so it's going to still be a challenge, and you have to work with therapists that you would have a comfort with and probably work with groups regularly so you can develop communication relationships. When I see people at Mayo Clinic who come from 3 or 4 states away and they're going home to a therapist, I have no idea what the skill level is of that therapist in order to do the things that I'm recommending. I try to put a very specific treatment plan into my note, but once again, you can't guarantee that they're going to be able to follow all of those particulars as we move forward. We are seeing as these guidelines continue to develop that fine tuning, if you will, is a key issue with that. And also knowing what to do more with chronic low back pain and central sensitization, which are entirely lectures on their own. This is DeLitto's last update, which was 2016. And they're still in this paper looking at trying to define who maybe doesn't need formal therapy. And so I usually in my office start the conversation to the patient with, we can do physical therapy, we can get very specific. You're an exerciser, would you like to just go back and start through an exercise regimen? I can help you with that. which way do you think you would like to go with the treatment? Because that's generally going to help us if we can get them into a treatment that they're comfortable with, and then we'll advance from there. If they're going to do it on their own, I need to see them a little more frequently or checking in, or they can message me now through the portal to say, okay, I made good progress, no problem. Or if I didn't, then I'm going to be more a little forceful in saying, well, we need to be more specific with our treatment program from there. But we still have those issues on the table, even as we move forward in 2021. Excuse me for 1 second before I take questions, because my dog's whining at the door here. I got to let her out. I put my email address there on the bottom. Once again, Nick and the research committee will have the slides. So if you email them, they will get you the slides. If you forget and email me, that's fine. I put it on the bottom though for any questions downstream, because right now you may or may not be seeing people with low back pain, depending on what your rotations are. And also, I'm happy to be a mentor to anyone in the group who's looking at PM&R, or even if you're not looking at PM&R. I just, over the years, my life has been in academic institutions at Florida, Northwestern, Kentucky, helping students and residents and getting the right place at the right time, hopefully. So why don't I get out a shared screen, and we'll take any questions.
You guys are welcome to unmute if you want, or if you feel like you need to, you can go to reactions and raise your hand, and I can unmute you guys from there. Otherwise, just anybody have any questions? Feel free to put them in the chat too, and I can read them.
Go ahead. I'll ask one. Thank you very much, Dr. Atchison. Very interesting. My first rotation was pain management with a PM&R physician. However, he's an MD, so he didn't have the osteopathic aspect. And I did actually get permission from him to do a few techniques in the office, as it's part of our curriculum, and really helped out some patients. And he was like, "You're going to steal all my patients." Because anyways, great experience overall. So I just wanted to know your take and perspective and treatments of low back pain of people with spinal stenosis, because I saw a lot of that. And he would usually do a procedure with the Vertiflex, I think it's called, the brand name, where you just put this little device in between the spinous processes, and it, alleviates the stenosis. So I saw a lot of that. And then also people with back surgeries that were having chronic pain, and he would do more epidurals and spinal blocks. So I was wondering if there is an osteopathic component for those two treatments, or conditions, I should say. So
before you mute, so the Vertiflex, what does it do?
He makes a little incision in the back with a person prone, and he hammers it down in between the spine. Why can I not think of the name?
The spinous processes.
Yes, like just up along the spinal cord, pretty close to it, and then it uses a screwdriver and just widens the gap, because he'll see on an MRI that there's almost no space between those spinous processes, and it alleviated their spinal stenosis. You usually do 2 levels at a time. We would just look on the MRI and see which areas were really, really bad. It's kind of treating imaging, but also, the patient came with the shopping cart signs.
Right. And so physiologically, I try not to answer questions without teaching. So basically what you're doing is you're trying to flex that segment, right? Yes. And you'll learn more about segmental mobility as you continue to work on osteopathy skills. But in that particular type of treatment for stenosis, what they are proposing is that if you add flexion to the spine at that level, that you're going to open up more space. So you would have more space for the spinal canal And remember, the spinal cord ends at about L1, so it's more the nerve roots coming down if you're doing it at L3 or L4 level. But in the relative flexion, you would also open up the lateral neural foramen. So if you have lateral stenosis pressing on your nerve root, you could be opening up the pressure on it. So unilateral versus bilateral claudication. Spinal stenosis diagnosis is a clinical diagnosis where you walk a certain distance and you get leg pain. You can get it in one leg, you can get it in both legs. If you are treating spinal stenosis on a film without the correct symptoms, then none of that is going to work. So as we all age, and I haven't had my spine looked at for a long time, but as we all age, we're all going to develop decrease in disc height. We're also going to develop some ligamentous hypertrophy. We're going to have some narrowing. Some people's pictures are extremely impressive as to how narrow their spinal canal is, and they have no clinical symptoms. So we should never be treating the picture. The treating of the symptoms with stenosis is, can I reduce the amount of pain into the legs when a person is ambulating? And so unless you do that measurement before you do any procedure, whether it's manipulation or a surgery or an epidural, which are common for stenosis, and then you repeat it again afterwards, you can't say for sure what you did, because looking at the picture and seeing the pictures better is no different than how many times do we hear about the surgery being successful, but the patient still has the exact same symptoms, and the hardware is stable, everything looks great, the pictures look great, it was a perfect surgery, however, the patient doesn't feel any better, right? So obviously it wasn't the right surgery for the right patient. That type of device has very limited literature support behind it. People will then argue it's because it hasn't been studied enough. So go study it, would be my opinion for people who are using it. And also the companies are promoting it. So I spent part of my career doing opioids. I've spent part of my career doing cognitive behavioral and pain program management with no opioids. We have a back pain epidemic. We don't just have an opioid epidemic. Now, the opioids have gained all of the negative attention, certainly because of the sad results for many people. But it's similar results with epidurals at times, surgery at times, these procedures at times. People want to do procedures because they generate a lot of revenue, but the right procedure at the right time. So I would challenge you to pull some of the literature and see what they were. We just went through a paper. What was the N on the study? Was the paper sponsored by the company who is selling the device? Some things along these lines are keys in research to look at, who do I apply this to? And if I have back pain only, it's clearly not indicated, because it's designed to flex the component at a level and open up space for the nerves. And with that, spinal stenosis requires you're having leg pain with ambulation at about the same distance. If you walk downhill, it'll be worse because you're leaning back. If you walk uphill, you can walk further. So at times I'll put people on a treadmill with a grade and say, see what you can do. I'll put them in the pool and let them walk to see, can they walk further without getting the leg symptoms, because the buoyancy helps separate a little bit. I mean, there's a bunch of clinical tricks in there with that. So you ask a question that didn't have one simple answer, and I'm sorry, but I'm going to teach you guys all to dig in. The digging in on this one is, I haven't looked at those papers lately. I don't know if there's newer information out about them. But in general, when it became popular to do it, the first group that came out doing those maneuvers stopped doing them. There were complications. There wasn't success rate. And in fact, they weren't being paid for anymore. And so, there's a lot of these things in back pain. My big picture lecture on low back pain is be careful, treat your patients like you would your mother. You don't want people doing a lot of things to your mother that aren't really, really indicated or safe to do. So in terms of your question regarding manipulation for stenosis, if you pull a very old paper by Kirkcaldy-Willis, he did do manipulation on a population of lumbar stenosis patients, and they got some benefit. This is a paper, probably, I'm guessing it's from the 50s, because it was an old paper even back when I was training. The thing you look at in all stenosis research is, what is the improvement? I emphasized to you tonight, 6 points on the Oswestry scale to me doesn't, I don't think in the clinic I can tell the difference. Kirkcaldy-Willis did measurements, it showed a benefit. This is a kind of a landmark osteopathic paper, which we've moved past, because whatever he was measuring, whether it was range of motion, well, range of motion isn't really an important issue. It's how far you're walking, right? And now you come up to things in today's world like epidurals. Well, people say epidurals work some for lumbar stenosis, and they do. I've ordered them. However, what you're talking about is you generally double or triple their walking distance. So if you can walk 10 feet, is it going to be helpful? You can walk 30 feet. Most of the research trials took stenosis patients that could walk about 100 meters, and whatever they did to them, they got up to around 250 to 300 meters. Okay, well, is that significantly changing your life? Stenosis is tough because a third get better, a third get worse, a third don't change. If you do surgery on them and open up those areas that are clearly stenotic, a third get better, a third don't change. There's probably not a third that gets worse, but surgery is not always helpful, even though it appears structurally it should be helpful. But you keep going back to, what is it you want to do? I have people come in with stenosis and they can walk half a mile to a mile. If I give them an epidural, I don't think they're going to walk any further. They're not going to double or triple their distance with an epidural. So those are the decisions you have to come to clinically. All of these tools work in some people. Your job is going to be selecting the right person to get the right treatment at the right time. Sorry, I know I'm running over. I'm happy to stay and talk as long as anybody wants to, but are there other questions?
Thank you.
If anybody wants to stay, they're welcome to. I'm going to go ahead and stop the recording though for now. We've included Dr. Atchison's email in the chat, and the slides will be available to those that want them afterwards. And you'll see his email on the last slide as well. So if you have any questions, go ahead and reach out and contact him. Before we stop the recording, again, we want to thank Dr. Atchison so much for your time. Fantastic presentation. So glad we were able to touch on low back pain, the low back pain epidemic, a little bit on the opioid epidemic, and how crucial being an osteopath and having our osteopathic skills are for helping these patients. So thank you so much.
Thank you. And nobody with any other questions?
I just thought it was an interesting insight.
DJ, I'm glad you're awake.
Oh, I'm still here. Yeah, I thought it was interesting what you just said there about how if you can give somebody, you have to look and see, is it actually going to improve how far they can walk or their metrics rather than just assuming it will.
Yeah, I think that's a it's a tough concept in a busy private outpatient office, and how do you measure those things? I mean, that would be one area where if your practice had a lot of low back pain, and perhaps in that pain practice that Alec was at, having their own PT might be a benefit, because PTs are good at doing measures and repeating those measures. I think some practices would even consider an exercise physiologist, because it's less costly to employ that person than it is a therapist. And yet you can get that person to measure what are the components of, you know, the 6-minute walk test or the treadmill or whatever you want them to do to measure your success. And quite honestly, in the world of pain, it's getting closer and closer where the insurance companies, including the governmental insurance companies, are going to demand, what is the change in life? Your pain went from 7 to 4, great. Can you walk further? Can you do your daily activities? Can you do the things that make you more functional in life? So being able to get those types of scales assessed is going to be important for the future. And I think you would find that as you go through training, you're going to see there is a lot of research on manipulation using a lot of different outcome tools. So we have one of the more robust areas of research that's been done. And I always joke about the fact that manipulation's reached the stage where people are manipulating the manipulation data results to manipulate what they want to tell their story on, because there's been so many trials done, but they all have a small number, they're a small N. And once again, the practitioner got to choose, I do a thrust here, or I do a muscle energy here, or, you know, I mean, there's variability in there. But we have, there's reviews of reviews of reviews regarding manipulation for low back pain. And they always keep coming up with some success, but it's which patient group, right? And so if you got a patient, and, you know, I think back to when I was doing more manipulation, it's, you know, here I would look at range of motion and daily activities, and can they go back to work, right? A big one is work, and people would come in because they couldn't straighten up and they couldn't go to work, and they needed to be able to move correctly in order to be able to do their work. And so anyway, there are tons of things out there as you're looking through and learning about manipulation. You'll be surprised how many studies there are.
Awesome. Thank you so much. I actually have a practical tomorrow in manipulation. So we got
Best of luck. I'm going to go ahead and stop the recording now real quick. People are fine, but just thank you everybody. And we're looking forward to the next session.
Thank you for your time.